This was really good. The last window we'll talk about is the subcostal window. Now, if you ask me what the importance of the subcostal window is in the cardiology exam, well, I think it probably has the least importance. I still believe it should be a constituent of every exam, but many cardiologists don't even do the subcostal window, which I think is a pity because it does give you very important information. If the patient cannot be positioned, then obviously the subcostal view is more important. And I would probably place it second to the apical view. It's different if you are under resuscitation conditions, because in that case, you don't want to interfere with the cardiac compression, so that view would probably be the favorite one. In any case, you have to know the subcostal window, and it provides a lot of information. To review, we image the heart from below the xiphoid. In other words, we're imaging actually from the abdominal region upwards towards the heart. And thereby we get a view which looks very much like a four-chamber view, only that the septum is very strongly slanted. And the chamber that we hit first is the right ventricle. Here is such a beautiful subcostal view. In this view, you can appreciate all the four chambers and get all the information you need. But obviously, you want to know how to get such a four-chamber view. And this will be the object of the next demo. What more is there to learn about the subcostal view? First of all, the positioning. You can optimize your image if you have a patient whose abdominal muscles are relaxed. So let the patient put his legs into this kind of a position. The next thing, don't forget to hold the transducer on the top. That allows you to be very shallow with your imaging orientation. And then let the patient inhale while you move the transducer towards the heart. And remember, the cursor or the marker of the transducer is pointing to the left, and you're imaging more towards the left shoulder. So inhale. So here we have the four-chamber view. Now, a problem you see here is a very frequent problem. We don't really see the apical portions. Why? Because we've got gas there. And gas does not permit us to see the heart, at least not in this portion. What else can you see here? Well, the right ventricle. We talked about the right ventricle already in the introductory course. Now, the right ventricle is a structure which can be very nicely visualized in the subcostal view. And you could easily also assess right ventricular function because you see the contractility, you even see the thickness of the right ventricle very nicely. On top, you have the ability to see the pericardium. So you can see even small pericardial effusions, which are very frequently located right here. We'll talk about that in the chapter on pericardial effusion. From the real patient, now to the simulator. In the starter kit course, I already explained you the anatomy of the subcostal view. Now I want to go a little bit deeper and show you a few more things. This is the subcostal four-chamber view. You remember, we have the right ventricle, the left ventricle, the right atrium, the left atrium, with the interatrial septum, which is nicely visible. Here, for example, you will then be able to actually visualize an atrial septal defect. Now, if you tilt the transducer more anteriorly, you will then see the ascending aorta, or the aortic valve, as a matter of fact. Now, this is very similar to the four-chamber view, where you tilt the transducer also anteriorly to see the five-chamber view. So you can do the same thing actually in a subcostal view. Coming back to the four-chamber view, remember, when you want to see more of the apex, all you need to do is point towards the apex. And you do that by moving the transducer more towards the left. So here you now see all you need to see. And this will be important if you want to assess left ventricular function. One advantage of the subcostal view is that you can nicely detect pericardial effusions, that it's possible to look at left ventricular function, and even right ventricular function, and that it is an optimal view to look at the interatrial septum. And the disadvantages? Patients who are very obese are sometimes very difficult to investigate from a subcostal position. Patients who have a very tight abdominal muscles, you cannot really put the probe into their abdomen to get a good view. And it might be very difficult if patients are very skinny. And finally, gas can be a problem, especially if you want to visualize the apex. Here are some examples. Here on the left-hand side, you see a patient with maybe mildly reduced left ventricular function, but the pathology that I want to show you is this echo-free space here surrounding the left ventricle and to a lesser extent here at the right ventricle. This is a pericardial effusion. On the right-hand side, another patient, this time normal left ventricular function, normal right ventricular function, but again, a pericardial effusion. We'll have an entire chapter on the issue of pericardial effusion, but at this point, just to demonstrate that the subcostal view is an ideal view to look at fluid within the pericardial sac. What about these images here? Maybe not as good as you would like to have them. The 2D image quality is not good, but you have a good Doppler quality. You are able to see a jet which crosses from the left atrium into the right atrium. This must be an atrial septal defect. The same can be seen here on this image, only that this ASD is much larger. You have a broad jet between the left atrium and the right atrium. And another atrial septal defect. This time I would say the size is somewhere between the two I showed you previously. Again, a jet from the left to the right atrium. What about this left ventricle? I would say it's mildly reduced, but the main problem here is that right ventricular function is significantly impaired. A patient who had pulmonary embolism following colorectal carcinoma and chemotherapy. He came in with massive dyspnea into the emergency department, and again, just one subcostal view kind of almost gave away the diagnosis that he has a right heart problem and pulmonary embolism. A subcostal view in a patient with cardiomyopathy, very large left ventricle, dilated left ventricle, and a small right ventricle. So you can even make the diagnosis of dilated cardiomyopathy from a subcostal view. And finally, this is a subcostal view that shows a mass right close to the right atrium. And this mass turned out to be a lymphoma. What am I trying to show you here? Well, with the subcostal view, it's possible to see the surroundings and structures which are located very close to the abdomen, and we are able to visualize tumors which are close to the atria. And remember, the right atrium is one of the structures in the heart which most frequently have tumors and masses. The subcostal four-chamber view gives a lot of information, but you can rotate the probe and get other views from the subcostal window as well. I would like to show you such a subcostal additional view and introduce a new structure that we can visualize with echocardiography, namely the inferior vena cava. What will we see? The liver again as the organ which is closest to the transducer, and then parts of the right atrium, maybe a little part of the tricuspid valve and the right ventricle, but mainly we'll be looking at the inferior vena cava. Let's see how we can do this in a patient. Now, how do you get to the inferior vena cava? It's two different motions. One is a motion towards the right shoulder, and at the same time, we're rotating the probe counterclockwise until all of a sudden we see the inferior vena cava here, how it enters the right atrium. You nicely see the fluctuations of the inferior vena cava, which are related to respiration. And if I let the patient inhale or actually sniff, you will see how it collapses. You see? This is an information which will be very important when we look at fluid status. But this will come in a later chapter.
Finding the IVC is so important. That's why I want to show you its anatomy once more on the simulator.
It's easy to understand why we have to perform such a strange motion to get to the inferior vena cava. It's because the inferior vena cava is to the right of the heart, actually. So we need to tilt over here, and you will see how the inferior vena cava will come into your field of view as soon as I move the transducer in a longitudinal direction. So here, all of a sudden, I would have the inferior vena cava in my field of view. See, this is the inferior vena cava. Now, if you place, or if you move the transducer a little bit, you will even sometimes see the superior vena cava come into the field of view. Remember, the superior vena cava and the inferior vena cava are almost along a straight line. So, right atrium, inferior vena cava, and here would be the superior, no, this is the aorta. This is the superior vena cava here. The inferior vena cava is an important structure because it reflects right atrial pressure, and it allows us to look at the blood flow that comes from the body back to the heart. And therefore, we are able to detect venous congestion. Now, this would be the inferior vena cava in a normal individual with normal filling pressures, with normal pressure in the right atrium. You see that the inferior vena cava is very slim. It actually collapses completely. You see that there are fluctuations in the diameter which are related to inspiration or respiration. And if you actually put color Doppler here, you will sometimes even see flow acceleration. Now, let's turn to a patient who does have elevated right atrial pressure. Now, in this case, the inferior vena cava is significantly dilated. I would say it's somewhere in the range of maybe almost 2 centimeters. And with respiration, you see no change in its diameter. This denotes usually elevated right atrial pressure or some problem related to maybe even backflow from a tricuspid regurgitation jet. This is an example of a patient who has an extreme form of elevated right atrium. And in this case, you not only see that the vena cava is massively dilated, maybe even 3 or 4 centimeters, but that this congestion translates also into the hepatic veins. So here you also have a dilated hepatic vein. You can measure the diameter of the inferior vena cava not only 2D, but also with M-mode. I personally don't like this method as much because sometimes, when the patient breathes, you always also get out of the plane, and thereby you have maybe pseudo size changes of the inferior vena cava. But I just want to show you that this is something that you can do, and the advantage of it would be that you can, for example, use a very slow sweep speed and thereby really document what happens during respiration. If you use color Doppler, it's possible to see how blood flow flows from the inferior vena cava into the right atrium, and as in this case, even retrograde flow, which occurs in the setting of tricuspid regurgitation. But in essence, it's something that's nice to do, but doesn't really have much meaning because there are many other ways of looking at tricuspid regurgitation, as you will see in the specific chapter. One last word with respect to the width of the inferior vena cava and right atrial pressure. It correlates, that's true, but not always. You will find patients who have a rather wide inferior vena cava, and even with inspiration it doesn't decrease significantly, but they still have normal or relatively normal right atrial pressures. Why is that so? Well, I cannot tell you. It's just been my observation that you see it very frequently in young women and young individuals. So be cautious. Okay, so now it's your turn to look at some images and find out what is wrong. Look at this inferior vena cava. Do you think that right atrial pressure is elevated? Well, the first thing that you might notice that you see a little spontaneous contrast here, right in the inferior vena cava here, which is nothing abnormal. You can see blood flow even in a normal inferior vena cava frequently. But the main finding here is that yes, the inferior vena cava is dilated, and not only is the inferior vena cava dilated, but also the hepatic vein. So I would say yes, with a high likelihood, this patient has elevated right atrial pressure. There's another indicator that right atrial pressure or a right heart problem might be the problem. Look at this here. This is an echo-free space posterior to the inferior vena cava, and this is a pleural effusion. You can even see part of the lung here. A patient who had massive tricuspid regurgitation and right heart failure and then developed pleural effusion. So the teaching message here, yes, you can see a pleural effusion also in a subcostal view. What about this patient here? What do you think his problem is? If you look at the inferior vena cava again, you will see that it's massively dilated and there are no fluctuations. So the likelihood is very big that the right atrial pressure is elevated. But in this patient, it's not only this elevation of right atrial pressure which is a problem, but it is this mass here, which compresses the entire right ventricle. What is it? It was a hematoma caused by rupture of the aorta, thereby leading to tamponade with consecutive dilatation and congestion of the inferior vena cava. And what about this inferior vena cava? It's a definitely dilated inferior vena cava, but the reason in this case is not congestion, but a large tumor. A very tragic case of a
relatively young woman who had a tumor of the pancreas, which growed right here towards the right atrium, extending into the right atrium. You can see the tumor here on the PET scan. This red area is the active zone of the tumor. You see that it grows right towards the right atrium, towards the heart. Now, what can we learn from this? Well, the subcostal view and the inferior vena cava are important additional views that allow you to look at a number of different pathologies and to estimate even right atrial pressure. Good. Now, this basically concludes this section on the subcostal view, and it also concludes our imaging primer. There are a number of different views that we did not show you here, which you will learn in the masterclass. But for now, I think it's enough. Good. For a very short review, what did we learn? We saw three very important windows. First, the peristernal window, then the apical window, and now the subcostal window. We taught you these views: the peristernal long axis view, short axis view at the base, short axis view at the level of the ventricle, the 4-chamber view, the 2-chamber view, the 5-chamber view, and the apical long axis view. And in this section, the subcostal 4-chamber view and the view where we're able to see the inferior vena cava. If you want to perform only point-of-care echocardiography, those are the views that you will primarily use: the short axis view at the level of the ventricle, the 4-chamber view, and the subcostal view. Good. So with this introduction to imaging, we laid the foundation to build your house of knowledge, and a foundation which will now help you to diagnose very important diseases. I hope we will see you there, and I hope you will join us together with Anna, who you met already, and Bruno, who you still have to meet.